Good morning. Welcome to today's lecture. We are going to look at the glaucoma. The term glaucoma refers to a group of disorders that involve many different pathological changes and symptoms, but have a common in an increase in intraocular pressure, which is abbreviated as IOP, that damages the optic disc, causing atrophy and loss of peripheral vision. Intraocular pressure of above 23 millimeters of mercury equals glaucoma. So we are saying glaucoma is diagnosed in most cases when the intraocular pressure is above 23 millimeters of mercury. 23 millimeters of mercury. Glaucoma may occur congenitally as primary disease or secondary to other ocular or systemic diseases. We are saying a patient who is presenting with this condition called glaucoma, they may present it in a way that they were just born with it, or it may present as a primary disease, or it is there because of an underlying cause, for example, coming from one of the systemic diseases, e.g., hypertensive retinopathy or diabetic retinopathy. The onset of the condition may be gradual and cause irreversible visual loss without any other noticeable symptoms. This simply means that in glaucoma, someone might be having this condition, but because they are unable to know that these signs and symptoms they are pointing to this condition, they may not be able to know that they have this condition. So when it has been diagnosed late enough, it may be very difficult to reverse the damage that has been caused. It may be sudden and produce blindness in a matter of hours. Sometimes instead of it taking a long period of time to bring about these signs and symptoms or damage to the eye, it may just present with sudden onset where the damage can be seen within hours. The amount of intraocular pressure that causes damage differs from person's eye to another. So like I said, the standard diagnosis of glaucoma is 23 millimeters of mercury. Above 23 millimeters of mercury, intraocular pressure should be above 23 millimeters of mercury. But we are saying individually we differ. Just like the way we differ on our faces, that's the way we even differ on our genetic code. So our bodies may not function exactly the way the other functions. So what we mean is in another person, intraocular pressure of 18 millimeters of mercury can be okay. But in another person, even 15 millimeters of mercury, it can cause glaucoma. Just like an open example that I can give, the situation of hypertension, which is high blood pressure. Some people, when they have high blood pressure of 130 over 90, it becomes very, very high to them. But meanwhile, others, when it is 135 over 90, they'll be just comfortable. So it depends on the norms of that individual. Blindness may be preventable if the disorder is treated early enough. So the Earlier the disease is discovered, the better the outcomes. Now let us look at the definition of glaucoma. Excuse me. Glaucoma is a group of ocular disorders characterized by increased intraocular pressure, like I said in the beginning, also capping of optic disc and atrophy of the optic nerve, with peripheral visual field loss. So in glaucoma, there are three things that happen. There's increased intraocular pressure, the escaping of optic disc, and loss of peripheral uh, visual field. Loss of peripheral visual field. This encompasses the definition of glaucoma. So it is a condition that presents with intraocular pressure, increased intraocular pressure, capping of optic disc, and atrophy of the optic nerve, as well as loss of peripheral visual field. Glaucoma can also be defined as a disorder characterized by increased intraocular pressure that may cause impaired vision, ranging from slight loss to absolute blindness. Glaucoma can also be defined as a disorder characterized by increased intraocular pressure that may cause impaired vision, ranging from slight loss to absolute blindness. Let us look at the etiology of glaucoma. Glaucoma results from an imbalance between the rate of aqueous humor production, referred to as inflow, and the rate of aqueous reabsorption, referred to as outflow. It is classified as primary or secondary to another ocular disease. So we really need to understand at this point, because this is where glaucoma is hipped on. So we are saying glaucoma is hipped on the production of aqueous humor, which is referred to as inflow. The aqueous humor which has been produced by the ciliary muscles, the ciliary bodies, it has to come into an eye. Then this aqueous humor is supposed to flow out of the eye, which is referred as absorption. So when the two are not balancing, for instance, what is being produced or the inflow is more than what is coming out, then there'll be an increase of aqueous humor inside the eye. Or at times the production may be just okay, but the drainage angle of the outflow is blocked, which will simply slow the drainage of the aqueous humor. Let us look at primary glaucoma. Under primary glaucoma, we have two types. We have closed angle glaucoma as well as open angle glaucoma. Now, let us look at open angle glaucoma. This results from degenerative changes in the trabecular meshwork. These changes block the flow of aqueous humor, which results in an increase in intraocular pressure, which results in an increase of intraocular pressure. So just like I said in the beginning, when you look at this open angle glaucoma, we're saying it is due to degenerative changes that takes place in the trabecular meshwork. The trabecular meshwork has the function to drain the aqueous humor that enters the eye. So when degenerative changes takes place, the drainage angle gets narrow. So the narrowing of the drainage angle brings about the decreased drainage of aqueous humor in the eye, leading to increased intraocular pressure. Open-angle glaucoma often runs in families and affects about 90% of all patients with glaucoma. We are also saying that the majority of people who present with glaucoma, they fall under open angle, and it affects about 90% of all patients with glaucoma. Open angle glaucoma also learn into families, or in other ways, we can say it is genetically predisposed, something that runs into family. We can also refer to genetic predisposed. Let us look at closed angle glaucoma. Closed angle glaucoma. So this has a sudden onset and may cause permanent visual loss in 48 to 72 hours. The other one in primary, we say it is chronic, but this one is sudden. As a sudden onset may cause permanent vision loss in 48 to 72 hours. So this one is quite severe. If you are affected with the closed angle glaucoma, you may be surprised that in less than 72 hours, you may have lost your sight. It results from obstruction to the outflow of aqueous humor due to angle closure. So we're saying what can bring about the sudden onset to blindness? What can bring the sudden onset of blindness in closed angle glaucoma is because it is because of the obstruction of the angle. It is because of the obstruction to the flow of aqueous humor, what we are referring to as the angle. So you find that when the aqueous humor has been produced by the ciliary muscles, the ciliary bodies, the aqueous humor flows in between the iris and the pupil. So when this angle has been closed, maybe due to inflammation of the pupil due to trauma, there will be no space which can be used for the aqueous humor to pass to the posterior and anterior chamber where it can be drained. So as a result, there will be just massive increase or sudden increase of intraocular pressure, leading to suddenly blindness. This type of glaucoma may be triggered by trauma, papular dilatation in patients with an anatomically narrowed angle, which we will explain. Also, stress or any other ocular condition that dilates the pupil, e.g., hemorrhage or swollen lens. So, like I said, when the pupil undergoes dilatation, it is going to press against the iris, making it very much impossible for intraocular pressure to pass through. An acute attack may be precipitated by a situation in which the pupil remains in a partially dilated state long enough to cause raised intraocular pressure, which I will explain. Now let us look at secondary glaucoma. This results from ocular or systemic diseases that block outflow of aqueous humor, e.g., inflammatory eye diseases such as the uveitis, other conditions, e.g., trauma, and systemic diseases, e.g., diabetes mellitus. So in diabetes mellitus, this is a condition which presents with raised sugar levels in the blood circulation. Sugar levels which are always above 7.0 millimoles. Then in hypertension, we are talking of raised blood pressure, which is above 140 millimeters of mercury, that is systolic, as well as above 90 millimeters of mercury for diastolic. So when there is raised blood pressure in a patient, the small blood vessels that supplies the retinal ruptures, predisposing to hemorrhage, hence leading to increased intraocular pressure in the eye because the passage gets broke by the blood that is coming from the ruptured blood vessels supplying the retina. Let us look at predisposing factors of glaucoma. Emotional stress, which brings about the rotation of the pupil. Then old age due to degenerative changes that takes place as someone starts to age. Then the congenital malformation, example in an anatomic narrowed angle, which can predispose someone to closed angle glaucoma. Then systemic diseases, e.g. hypertension and diabetes mellitus, which I've explained already. Then in uveitis or iritis, inflammatory conditions of these brings about the blockage to flow of intraocular pressure from the ciliary bodies to the iris, then posterior and to the interior chamber where it gets drained. Then trauma to the eye, which brings about the dilatation to the pupil, which blocks the flow of intraocular pressure. Then pupil dilatation due to drugs. Pupils can be dilated due to administration of drugs such as mydriatics, which will prevent the normal flow of intraocular pressure. Then thrombosis of the central vein of the eye can also predispose someone to glaucoma. Now let us look at the pathophysiology of glaucoma. What really happens when someone has glaucoma? Like I said, phase 3, increased intraocular pressure is determined by the rate of production and the flow of aqueous humor, what is being produced and what is coming out. Aqueous humor is produced by the ciliary body and flows out of the eye through the canal of sclera into the venous system. So when aqueous humor has been produced by the ciliary body, it flows out of the eye through the canal of sclera, which forms our drainage angle. An imbalance between production and drainage of aqueous humor leads to increased intraocular pressure. So if what is being produced and what is coming out, there is imbalance between the two, then it leads to increased intraocular pressure. This imbalance may result from overproduction or obstruction to the outflow of aqueous humor. Like I mentioned, saying, the imbalance can come from overproduction or obstruction to the outflow of aqueous humor. It can either be as a result of overproduction or what is coming out or what is being drained from the eye is less than what is being produced. Intraocular pressure of greater than 23 millimeters of mercury requires thorough evaluation. We need to probe further, investigate why is there increased intraocular pressure so that we are able to find the cause of that increased intraocular pressure. Increased intraocular pressure reduces blood flow to optic nerve and the retina, leading to ischemia and loss of function. So when there is increased intraocular pressure, it reduces blood flow to the optic nerve, which controls the eye and the retina, leading to ischemia and loss of function. So whenever there is reduced blood flow to the optic nerve, we are going to say that there is ischemia, which is going to develop, eventually leading to loss of function of the eye. The visual impairment from damage to the retina and the optic nerve is permanent. The visual impairment from damage to the retina and the optic nerve is permanent. So when the retina has been damaged and the optic nerve has been damaged, in most cases, this is permanent. It is not reversible. So that was the pathophysiology of glaucoma. Now let us look at clinical manifestations of glaucoma. Clinical manifestations of glaucoma include severe pain which is felt above the eye, severe pain which is felt above the eye due to damage of the retina, also headache due to uh, due to damage of the optic nerve, then redness of the eyes due to inflammatory process, cloud and the blurred vision due to damage of the retina, dilatation of the pupil due to damage of the pupil, which makes it to undergo dilatation, then lacrimination due to irritation, nausea and vomiting, eyeball feels hard on palpation due to clots of blood that might have formed due to rupture of blood vessels supplying the retina. Patient's eyes look hazy and cornea may be edematous due to inflammatory process. The intention is increased because of increased intraocular pressure. Then reduced peripheral vision due to damage of the optic nerve. Let us look at the management of glaucoma. Management of glaucoma, first of all, we need to do history taking. We need to do history taking. So ask the patient about ocular symptoms related to glaucoma, such as pain, redness, central, tunnel vision. So these are pointing to signs and symptoms of glaucoma. Obtain information about general medical history regarding systemic diseases such as diabetes, hypertension, medication, allergies, and family history of glaucoma and retinal detachment. All these can also point out to damage of the eye in one way or the other, such as the degenerative changes that can be associated with it. Degenerative changes that can be associated with the retinal detachment. Also, medication such as the mydriatics, which brings about pupil dilatation, hypertension, which brings about rupturing of blood vessels supplying the retina, as well as in diabetes, these blood vessels supplying the retina, they get damaged due to high levels of sugar. Diagnostic studies can also be done. Among them, we have tonometry to establish intraocular pressure. You can do tonometry just to establish the intraocular pressure to know if the intraocular pressure is high or it's normal. Then we can also do slit lamp examination used to assess the structures and depth of the anterior chamber. In doing or performing slit lamp examination, want to know the structures of So I was saying in slit lamp examination, you can do this to assess examining the structures of the deep or the structures and depth of the anterior chamber. Then under ophthalmoscope to examine the optic nerve and large blood vessels. You can also do visual field examination to determine the peripheral vision. You can also do gonoscopy to visualize the drainage angle, if it is patency or it is blocked. Let us look at medical management of glaucoma. Glaucoma is an ophthalmic emergency, hence the aim of treatment is to reduce increased intraocular pressure and to correct the cause. If the cause is anxiety, give morphine to allay anxiety and reduce pain. So you can see that if the patient is having anxiety as a cause of glaucoma, we can give morphine to allay anxiety. We can also give Pilocarpine. You can also give pilocarpine 1 drop per minute for 5 minutes. Then 1 drop every 5 minutes for 15 minutes. Then 1 drop every 15 minutes for 1 hour. Then 1 drop every 30 minutes for 2 hours. Pilocarpine is used to constrict the pupil. So pilocarpine is used so that the pupil can be constricted, which underwent dilatation. We can also give diuretics such as Diamox 250 milligrams QID is given to suppress the production of aqueous humor in situations where intraocular pressure is caused by overproduction of aqueous humor. So you can give Diamox 250 milligrams to reduce the production of aqueous humor. You can also give Timolol, a beta blocker is given to reduce intraocular pressure production. Let us look at surgical management. Surgical management is done when medical management has failed. It's indicated to halt the progression of visual loss and optic nerve damage. So we are saying surgical management is done when medical management has failed, and it is done so that we can stop the progression, of visual loss and optic nerve damage. We want to stop the damage of visual loss and the optic nerve. So one of the surgical procedures that can be done is peripheral iridectomy. Peripheral iridectomy can be done to keep the flow of aqueous humor parted if the angle is not damaged or closed. So this is done so that we increase the drainage of aqueous humor. Another surgical intervention that can be done is trabeculectomy. Trabeculectomy, it can be done also where an extraocular drainage is created. So trabeculectomy is done so that we put an extra drainage to improve the drainage of aqueous humor. We can also do goniotomy, or goniopuncture is done by cutting off the thinned tissue of the drainage angle and creating an opening in the canal of sclera. So you can also see that these interventions surgically, they are aimed at increasing the drainage of aqueous humor so that we reduce the increased intraocular pressure which is in the eye due to reduced drainage output, what we referred in the beginning as the outflow. Secondary glaucoma is managed by treating the underlying cause such as hypertension and diabetes mellitus. Important nursing interventions: administer prescribed drugs collected to achieve reduction in intraocular pressure. Also apply cool compresses on the patient's head to relieve pain. You can also administer prescribed analgesics. You can also administer prescribed analgesics. In postoperative care, most surgical interventions are done on outpatient basis. So these patients, they are nursed as they are treated from the outpatient departments in the OPD. In most cases, they don't need to be admitted in the ward. So instruct patients and family on eye hygiene to prevent contamination, dressing, or to prevent contamination or to prevent contamination of medication. Here we mean like when you want to apply the medication in the eye that is affected, you don't have to, when applying the medication, you don't have to come into contact with the eye when applying the medication, because the microorganisms will come into contact with the medication. Hence, the medication will be contaminated, in that when you want to administer it to the other eye will be contaminated. So patient has to be taught as well on dressings, how to change them. Then teach patient and family on signs and symptoms of infection such as fever and when to report for medical interventions. It is very important that the patient should be taught on these signs and symptoms of infection so that the patient is able to come back before the situation worsens or before the condition worsens. Health education, glaucoma is preventable. Glaucoma is preventable. Patients should be taught about risk factors and how to prevent them. So here we mean if someone is hypertensive, they need to control hypertension if glaucoma is to be controlled. If they are diabetic, they need to control their diabetes mellitus if glaucoma has to be preventable. Then in nursing care, problems that can be problems that can be formulated from this condition who have pain, anxiety, high risks for injury, knowledge deficit, sensory or perceptual alterations are some of the nursing care problems that can be done. Then under nursing problems or diagnosis may say anxiety. Nursing diagnosis could be anxiety related to inadequate knowledge on the disease process manifested by frequent asking of questions. Then the patient will experience a reduction in anxiety following acquisition of adequate knowledge on the disease within 24 hours. Then interventions will be explained to the patient the disease process in simple possible terms so that he or she understands it. Allow the patient to ask as many questions as possible and answer as honestly as possible. Maintain a calm atmosphere to promote psychological care. Expected outcome or evaluation. The patient has experienced a reduction in anxiety following the exertion of knowledge and is resting calmly within 24 hours. So you can do one and the same to other problems that we've listed in the problems that can be associated with glaucoma. Then you can try to practice how to write these nursing care plans. Unless there are questions, we've come to the end of our day's presentation on glaucoma. I thank you so much for paying attention.